This video is going to be an approach to jaundice. It gives you an idea of when you see elevated bilirubin, what the most likely diagnosis is going to be just on knowing what kind of bilirubin it is. The diseases that are discussed in this video appear elsewhere in the course, so we're not going to spend a lot of time going through pathology presentation and diagnosis. This is primarily going to be a discussion of jaundice itself. Jaundice is the yellowing of the skin and eyes. Generally, the way it works is as the bilirubin begins to rise, first the sublingual mucosa turns yellow, then the ears, then the eyes, sclerolicterus, and eventually the entire skin becomes yellow. So when you see someone looking like a banana, they don't have a tan, they've got jaundice, and their bilirubin is likely elevated. When you think of bilirubin, I want you to think of this system. There's the blood that brings the bilirubin to the liver. This is going to be prehepatic. The liver does the processing of bilirubin. This is intrahepatic. And then there's going to be the biliary tree, which takes bilirubin and delivers it to the duodenum to be eliminated in the stool. This is posthepatic. Let's discuss where bilirubin comes from. How do you get an elevated bilirubin? Well, bilirubin is essentially hemoglobin transported in the bloodstream. This is red blood cell hemolysis. As red blood cells die, it doesn't matter how they die, whether it's intravascular hemolysis or extravascular hemolysis in the spleen, it doesn't make a difference. When red blood cells die, they release free hemoglobin. And free hemoglobin can't be floating around in the blood, so haptoglobin grabs onto it and forms unconjugated bilirubin. Unconjugated bilirubin is the means in which bilirubin is transported to the liver. At the liver, a bunch of stuff happens, but the rate-limiting step, oppress your attendings and your friends, is 2,3-UDP glucuronol transferase. You don't have to know the name of that enzyme anymore. I know you studied it for step 1. But 2,3-UDP glucuronol transferase is the rate-limiting step that turns unconjugated bilirubin into conjugated bilirubin. And conjugated bilirubin is eliminated through the stool. It is the accumulation of either unconjugated or conjugated bilirubin that leads to jaundice. And it doesn't matter which one it is, both will turn you yellow. So let's explore this system. Let's just say that there is an increase in red blood cell turnover. There's more hemolysis. That means there's going to be more free hemoglobin, which means there's going to be more unconjugated bilirubin. If more unconjugated bilirubin is brought to the liver, more conjugated bilirubin will be created. But because a rate-limiting step is 2,3-UDP glucuronol transferase, there's going to be a lot more unconjugated bilirubin than the liver can handle, so there'll be more unconjugated bilirubin than conjugated. In that setting, prehepatic jaundice is primarily going to be an elevation in the unconjugated bilirubin. Things that do that, as we said, are hemolysis, but also reabsorption of a hematoma. So if you see an elevated bilirubin, and most of it is unconjugated, that is, the direct bilirubin is low, then you know you have prehepatic and you look for hemolysis or hematoma being reabsorbed. Let's go to the other side of the equation. If, for example, the outlet were obstructed, conjugated bilirubin couldn't get out, but there's no change to hemolysis or free hemoglobin, so there's no change to unconjugated bilirubin. There will be an accumulation of conjugated bilirubin that spills back out into the blood. So if you see an elevated bilirubin, and most of it is conjugated, that is the total and the direct approach each other, you know that it's probably a posthepatic jaundice. Posthepatic jaundice is mostly conjugated. And this comes from obstruction. And there's two types of obstruction. There's the one that's painful and the one that's painless. Painful jaundice is gallstones. And painless jaundice is going to be cancer or stricture. We can also throw in here PSC and PBC. Primary sclerosing cholangitis, extrahepatic ducts, primary biliary cirrhosis, intrahepatic ducts with still some forms of painless obstructive jaundice. And I saved intrahepatic for last because it's the most complicated. It's more than just 2,3-UDP glucuronoltransferase. There's an enzyme that has to get the unconjugated bilirubin into the liver, and then conjugation, and then there has to be another enzyme that excretes it into the biliary tree. And depending on what's broken is going to decide whether there's an elevation in conjugated or unconjugated. To keep it simple, we saw that posthepatic is primarily direct, prehepatic is mostly indirect or unconjugated bilirubin. So it's safe to say that intrahepatic will be a mix of the two, but that's not true. So let's look deeper at some of the metabolic or genetic diseases that might come up, knowing that this is more useful in pediatrics than it is in adult medicine. Crigler-Najjar and Gilbert's. These are going to be more likely to be unconjugated, has to be uptake, whereas Dubin-Johnson and Roters happen to be conjugated, more of excretion. And then anything that causes a hepatitis or cirrhosis can lead to an elevation in the bilirubin, and it's going to be a mixed picture. Some pinpoints. Crigler-Najjar, you either have the really bad form, where you're dead as a child, or you have the not so bad form, which is essentially Gilbert's. Both of them cause an asymptomatic rise in the bilirubin when under stress. So if someone gets sick for another reason, their bilirubin goes up. No big deal. Nothing to worry about. Dubin-Johnson and Roters are basically the same thing, except pinpoint Roters has a black liver on MRI. Just know it and move on. Hepatitis and cirrhosis can cause mixed picture depending on how bad the liver damage is. Okay, so we've got pre, post, and intra, some general categories of the diseases you might encounter. But why does this matter? This matters. We're having this big discussion in pre and post because you want to come up with a clinical diagnosis. And you can use a few clues from the history and physical to get you there. Remember, everyone's yellow. So what's the difference between conjugated and unconjugated? The big difference is going to be that conjugated is water soluble. And because it's water soluble, it cannot cross the blood-brain barrier. But also when it is excreted into the urine, it's stuck in the urine. It can't pass through a lipid membrane. So it does have urinary excretion. And if there's a bunch of pigment, the bilirubin, in the urine is going to be dark. Unconjugated bilirubin, on the other hand, is fat soluble. And so it can cross the blood-brain barrier. And it is not able to be excreted in the urine. And since if it gets into the urine, it can pass right through a lipid bilayer, it can simply go back into the bloodstream, so the urine will not be dark. This matters more in pediatrics because fat soluble means it can cross the blood-brain barrier and get into the basal ganglia. You can get kernicterus. In the adult, the brain is already formed, so it doesn't really make a difference. But you can use the fact that there's dark urine and they're yellow to know that it is probably conjugated hyperbilirubinemia, which means an obstruction. Or the opposite, where it's not, and it's probably hemolysis or reabsorption of a hematoma. The specifics of all of these diseases are discussed elsewhere in the course, but I want you to see what it means. If you find in mostly unconjugated hyperbilirubinemia, you look at a blood smear. You're trying to figure out what hemolysis it is. If you have a mostly conjugated hyperbilirubinemia, you get an ultrasound because you're looking at the biliary ducts. Knowing that there's more advanced testing like MRCP, ERCP, and specific blood tests for the individual types of hemolysis. But just looking at this approach, you'll be able to get a pretty good idea of what's going on. And that's jaundice.